Welcome to Farmfield, one of the Priory Group's secure hospitals. Priory Secure Services is a specialist provider of secure mental health services working in partnership with the NHS. The hospitals provide short, medium and long-term secure care and treatment personalised to individual patient needs. I'm going to discuss the complex issues surrounding personality disorder, how it is diagnosed, the effect on a patient's life, how it can be treated, and the possibilities for recovery and community resettlement. In addition, my colleague Kate Law, one of the lead psychologists in this field, will discuss psychological treatment. Psychiatry uses specific types of classification system to diagnose categories of mental disorder, including personality disorder. Typically, personality disorder can be considered as a chronic disturbance in how an individual relates to themselves, to other people, or their environment. And that type of disturbance must cause disability or distress to the individual or others. For personality disorder, these types of problems must be unusual if one takes into account the individual's social and cultural background. And of course, the disturbances mustn't be due to any other type of mental illness. Now, we all have personality traits that may be strengths or perhaps we may wish to improve. But for personality disorder, there must be clear evidence of problems that cause distress. Personality disorder is a common type of clinical problem that we encounter in mental health services. It's harder to know how common the condition is in community settings because it's a difficult area to carry out proper surveys. But there's some recent work suggesting that personality disorders present at a relatively common rate to GPs, for example 5 to 10% of consultees, and of course becomes much more common as we get to more secure environments in mental health services. So for example, in prison settings, about 70% of adult men in remand settings will have at least one type of personality disorder. Typically, clinicians would carry out a very thorough history, collecting information from the client as well as any informant that knows them well, and of course lots of collateral information about how the individual gets on in their day-to-day life, so work records, school records. We would also carry out sophisticated psychometric evaluations of the individual, getting a sense of how their personality traits lead to difficulty, and that really helps inform treatment. We're looking for, I suppose, four main areas of problems in cognitions, so how the individual perceives themselves or others, their ability to regulate their emotions, how they relate to other people, so their interpersonal behaviour, and finally, how they control their behaviour themselves, so their impulse control. And typically, we're trying to find a functional link between those problems and any kind of disability that they have. There are several types of personality disorder, and most classification systems try and group them together. So, for example, there may be one cluster of individuals who are particularly sensitive, socially withdraw, and have difficulty perceiving the world around them. There's a second group who perhaps have difficulty with appreciating their own identity and regulating their emotions, and this can be associated with antisocial behaviour. And then a third group who perhaps are dependent or perhaps have neurotic type problems, anxiety and forming relationships can be a difficulty. Typically in secure environments we would encounter all these types of personality disorder, and an individual may actually suffer from more than one type. The causes of personality disorder are complex, and it's a very exciting and rapidly evolving field of research. Some personality disorders are likely to be explained by a genetic vulnerability, so really quite a complex interplay between different genes. But it's likely also that the environment plays a part as well. So for example, with antisocial personality disorder, there's emerging evidence of a strong genetic linkage to the disorder, but also the fact that negative life events may explain how that disorder actually manifests itself in adulthood. And I guess the exciting thing is that this gives us clues about potential preventative treatments in adolescents for certain types of disorder. A diagnosis of personality disorder should only really be made if there is evidence of problems in how the individual functions in many areas of their life, for example, their relationships or their work. But of course, personality affects how any of us will engage with mental health services. It will affect how we seek help, and in fact, whether we seek help. It will influence what we do with that help and how we cope with problems around us. It influences our lifestyle choices and whether they're healthy or not. And it influences whether we're able to refrain from risk-taking behaviour, especially during times of stress. So it's not surprising that some personality disorders are associated with higher levels of mental illness, such as mood disorders, and also, of course, harmful behaviours such as addictions. The difficulty is that the combination of a personality disorder and another type of mental illness makes the latter much harder to treat. So there's quite a burden on the individual and the people around them. Most countries in Europe and North America have struggled to provide a socially inclusive, comprehensive service for sufferers with personality disorder. There have been some very exciting developments in the United Kingdom. And I think the key message is that personality disorder services should not develop in isolation. So, for example, the Medium Secure Ward at Farmfield is only part of a tiny part of a managed network within Priory of services that extend from higher levels of security right through to the community for different age groups and also for male and female patients. The services can be broken down into different types of tiers. So at one area of the continuum, tiers 5 and 6 would include secure environments providing care for personality disordered prisoners who haven't been able to seek help in healthcare settings. So we would provide psychological treatment programs for that group. There are also services for patients who have stepped down from high secure environments that require ongoing psychological programs as well as treatment for their mental illnesses. At the other end of the spectrum, so I guess tier 1 to tier 3, we have units like Sturt House that provide residential and also daycare programs. But I think the most exciting part of this is the community case management initiatives that allow extension of these programs right into the individual's local networks, working in partnership with local stakeholders to make sure that these individuals are resettling with vocational opportunities, training and education, as well as the support from mental health services. And that, I think, really is the tableau for an effective treatment programme.
The treatment that we offer is based around a cognitive behavioural therapy and skills-based approach, which is underpinned by the recovery model. The treatment that we offered is offered in 3 stages. In stage 1, we look at a comprehensive assessment of the client's needs. This will include assessment of the personality disorder and a risk assessment, and we'll look at the link between the core pathology and forensic issues. In stage 2, we look at treatment. In this stage, the client will be offered a mixture of group-based treatments and individual work. This work will, in terms of the group work, will look at groups such as cognitive skills, the anger management and substance misuse, and we're very much linked to what the client's treatment needs are. Individual work may include, for example, schema-focused therapy, or if the client is presenting with borderline personality disorder, and may look at dialectical behaviour therapy. The final stage is the relapse prevention stage, and in this we will bring together the individual and group work for a reassessment and to build up a comprehensive relapse prevention plan for the client. It's expected this sort of treatment will last around 18 months to 2 years, and then will be a further assessment of whether the client has more needs.
Many people with personality disorder are able to live healthy and safe lives where there's the right balance between independence and also receiving support from mental health services and other important people in their social network. The evidence for those leaving secure environments is less extensive, but I think what makes clinical sense and seems to be coming through from the research is that a healthy recovery is most likely if the service user believes that they're included in the treatment that they're receiving, they have hope for the future, and ultimately learn to live with their personality disorder rather than being defined by their personality disorder.